Today, I would like to talk a bit about pain. And most people will come to see us because they have pain, at least in my clinic. That's what tends to happen. And pain is a complex sense that is necessary. It helps us preserve our body, and it provides an evolutive advantage. It's a sense like your eyesight or your hearing. It allows you to experience the world. And it's a sense that it can go wrong, and it can go wrong in different ways. Paul Brand wrote this book, Pain, the Gift Nobody Wants, because it is really a gift, but none of us want to be in pain. But this is a patient of mine with a diabetic neuropathy, and that's what happens when you have lost the sense of pain. He keeps injuring his fingers. In different days, he gets different injuries. He gets burns when he's cooking. He gets cuts when he's using knives, because he doesn't realize until he has done it. He has lost the protective sensation, and that's a disaster. There are also very rarely children that are born with congenital absence of pain, and they have a very difficult life because they keep injuring themselves and they don't even realize. So not having pain is a disaster, and having pain is a blessing in a way. And we all know what pain is because we have experience of it. But when you come to defining it, it's not easy. And the International Association for a Study of the Pain spent about 2 years arguing and discussing among them what the definition of pain was, and they came up with this: an unpleasant sensory and emotional experience. And this definition has been very criticized over the years. So they reviewed that and they discussed for another year. And in 2020 came with this, which to me looks very much the same, to be honest. But it is difficult to define better than that. So just remember, pain is a sensory and an emotional experience, both at the same time. If I hit my thumb with a hammer, what will happen is that I've got some nociceptors, free nerve endings, and that will generate a transduction of that impact to stimulate these receptors and send a nerve signal going up the arm. And this transduction can be provoked by intense forces and pressures. So if you press very hard on your finger, it will hurt. By high temperatures, usually above 45 degrees, that will be painful. It can be caused by strong chemical solutions, cold, anything that causes tissue damage, or by, for example, putting in contact with bradykinin or prostaglandins. And that gives us a gate to management of the pain. So once this signal has been transducted, the nerve is in charge of a transmission, and it does it through two different fibers, C fibers and A delta fibers. The L delta fibers are large fibers that conduct fast, like 10 meters per second. So it takes a tenth of a second to get from my thumb the signal to my spine. And it can be activated by thermal or mechanical stimuli, and it's sharp pain, short duration, localized pain. While the C fibers in the skin and deeper structures activated by thermal, mechanical, or chemical stimuli, and it's properly localized. But they connect to all the C fibers, and they're involved in driving inflammation. And this is not something that we measure very well. If you do neurophysiology, normally you're measuring the big fibers, not the little fibers, which are more involved in chronic pain. Once the signal gets to my spinal cord, there is a relay neuron, and then you'll remember from your days of anatomy that there is a decussation, and the spinothalamic tract takes the signal all the way to the thalamus in the brain, and this is where the pain sensation is caused. From there, it goes to the cortex, And that's where the pain perception is caused. But it is not just these pain signals that light the map on your brain of your pain homuncle, where the hand is very well represented. So the homuncle has big hands because there are lots of receptors in the hand, and it lights up on your cortical brain like an alarm in a house where a window is broken, and it tells you what's happening and where it's happening. And that is part of localizing the pain and of a multisensory experience. Because if I hit my thumb with a hammer, I get the pain, but also get the feeling of touch. And I've also was watching it, so I get visual input, and also heard the crack when the hammer came in contact with my finger. So that multisensorial experience will inform me of what's happening. And then I can put it together with my previous experience of hammering my thumb, and I know what's happening and what's going to happen. And that is going to create an emotional response to it. And the interpretation of pain is very important, because if you think that something really bad has happened, your anxiety is much higher. But pain can be interpreted in several ways. For example, I was talking to somebody who had a tattoo done recently, and I asked her, was it painful? And she said, no, I had the sensation of pain, but it was quite pleasurable. The reason is I wanted to have a tattoo for a long time to remember my granddad. But I thought my mother would not approve of that. So I didn't. But then I talked to my mother and she said that was fine. And I was so relieved. And I wanted to do it for such a long time that the sensation of having it done felt really good. Which is interesting because the sensation is of pain, but the perception is that you're doing something good. Gymnasts get trained to do stretching exercises before competition. And they get trained to appreciate that doing the stretches are painful. And there is a certain level of pain, that's the right level of pain. And they learn the difference between that pain and a bad pain from an injury, something else. So before competition, you'll see them stretching, and they're looking for a certain pain because they know that's associated with a good performance. Also, long-distance runners have a different perception of pain. And I thought that they get used to pain and they toughen up. But in fact, there is a recent study in Germany where they looked at junior runners and they checked the ones that were less sensitive to pain. They were able to bear up the pain better. And they went to see them 5 years later. And the ones that were, let's say, less sensitive to pain are the ones that were still doing long distance running. So people like me with a low threshold for pain abandoned running marathon very, very early. Apart from these ascending pathways that take the signal from the periphery to your cortex, there are some descending pathways, and they modulate pain. And that means that they can decrease or increase the intensity of the pain, of both the sensation and the perception. And if this modulation system goes wrong, then the pain can be felt, for example, very intense when it shouldn't. So the pain is a sense, and it's a complex sense. What could go wrong with it? Well, several things can go wrong. Pain is very good to tell you that something bad has happened, that the nociceptive stimulus exists, localize your attention and focus what you're doing there. But if the nociceptive stimulus persists, and that alarm is constantly on, it makes your life miserable. An example of that is if you see a patient with glomus tumor in the thumb, they'll come in and won't be bothered to have the thumb amputated. They just want something done. Because if you are in chronic severe pain, that puts your life on hold. You cannot use it. You cannot look after yourself. You cannot sleep. You cannot work. It's very disabling. The other thing that can go wrong is when nerves become generators of pain. So if a nerve starts generating pain signals for some reason, and that becomes chronic, that's very difficult to manage because the pure pain that generates is very intense. And if you want to know more about that, read the papers by J.L. Ochoa a guy from Portland who wrote a lot between the 1980s, 90s, and the 2000s about this, and very clever papers. And one of the things I learned from him is that if a nerve is ischemic, it generates pain. And that can be because of injury or because of compression or because there is a scar around the nerve. That's enough to make the nerve a pain generator. The other thing that happens is that the system becomes too sensitive. And then what happens is that impulses are felt like pain when they shouldn't, just because the threshold is too low. The extreme of that is when even light stimulus cause intense pain. And the other thing that happens is that pain is created for a gain, which can be conscious or unconscious. And because there is a certain gain, the brain creates pain without the peripheral stimulus. So let's look at an example. This is a typical patient I see, a 70-year-old man that comes with decreased movement of the wrist, and he had an injury years ago, and he comes now with a degenerated wrist that's painful with movement of grip, better with non-steroidal anti-inflammatories, no pain at rest, no pain at night. It's only when he uses it. And this, we know he has pain because he's got osteoarthritis of the wrist. So we understand that. And this is the kind of pain we are good at treating. By the way, what I did for this man is a denervation of the wrist. And just to comment on that, denervation works because we interrupt that peripheral signal going to the central nervous system. But also because to have inflammation, you need innervation. If you have somebody who has got a denervated joint because of a neurological cause or whatever, and then they develop, let's say, an inflammatory arthritis, you would not get inflammation in the denervated joint. And it's interesting that sometimes I notice that I've done a denervation for somebody, the pain is less, but also the synovitis and the swelling is less. And that's because you need the joint to be well innervated to get inflammation. Another typical patient of mine is somebody with wrist instability. And this happened to be a doctor, a consultant, and if I give some dynamic views, he's got a scapholonate instability. I understand that. And then I did an arthroscopy for him that shows that he's damaging the joint. So all this is nociceptive pain, which we are good at treating. And the pain has certain characteristics that the patient recognized. And a good example was this lady who had a dull ache at the base of the thumb, diagnosed as osteoarthritis. She had a trapeziectomy, and she came back and said, oh, the pain has changed. It's now worse, it's severe, it's constant, and I get pain at rest and at night that I never had before, and it's extremely tender. Some of you have already guessed what the problem is, that she has got a scar that's very tender there because she has a neuroma. So what she's telling you is explaining to you the characteristics of the pain, and that nerve pain is different to the nociceptive pain. And the patient will tell you that if you listen to them. And the typical one is the radial nerve, which is quite a tender nerve and is prone to problems. And not only pain, but allodynia. Allodynia is slightly different. It's pain resulting from a light touch, a light stimulus, and it's a type of dysesthesia, which means that touching the skin causes an unpleasant sensation. You'll have a neuroma if you had a radial nerve injury with a positive stimulus test, but you also have the allodynia. And the allodynia is interesting because if you think of it, people who have had a complete division of the radial nerve, they still have allodynia. And it makes you wonder, how does the signal from the skin when I touch it gets to the brain saying that that is painful? And Alberto Hugh wrote an interesting paper years ago. And what he demonstrated is that the allodynia is not transmitted by the radial nerve. It's transmitted by the posterior interosseous nerve. And you can prove that because if you put one little bit of local anesthetic by the posterior interossei nerve, the allodynia will disappear in many cases. The tinels and the pain over the radial nerve will still be there, but not the allodynia. And all you need for that is a needle, a syringe, and a local anesthetic. So this is the cheapest clinical test you will ever use. It's about £1 in the UK, about €1 in Europe, or about $1 in the rest of the world. And this is one of my patients. Let's see if I can get this to run. Tell me what's the pain like you get there?
It's, when it comes, it's powerful, and I'd rather have a cesarean than have that pain.
Okay. Do you get pain? Do you get pain at night?
Especially when I go to sleep, I can't lie on that side, and I can't. The arm gets pins and needles.
Okay.
And I have to get up for the pain.
Okay. And do painkillers help?
No.
Okay. And where is the pain, you think?
Comes up here and up to there. Up, and it's starting to work its way where this feels tight and tense.
Okay. Right. So this is the good hand.
Yeah.
If I do that, is that normal?
Yeah.
Okay. Now, if I do that here very lightly.
That feels like a tickling sensation.
Unpleasant?
Yeah.
Very
I don't
unpleasant.
like anybody touching my thumb and hand, sorry.
And what about there?
It's so tender.
You don't like that at all,
No,
do you?
on the scars, it's very tender.
Okay. Okay. So I'm going to put a little bit of local anesthetic here. So yeah. I'm just putting a bit of local anesthetic around the posterior interossei nerve. For me. So just 1 ml. Feel the pressure of this going in. 1 milliliter of local anesthetic is enough. And then we're going to give it a few minutes, and we're going to have a look at. We're going to have a look at it in a few minutes. Yeah, is that okay?
So painful.
Sorry about this.
You're all right.
Okay, all done. Just press there with your finger for a second. Okay. Touching now. How does that feel now?
No pain there.
Is the pain gone?
Pain's gone from there.
Excellent. So that's an example of. Tell me what. Aladinia transmitted by the posterior interossei nerve. Of course, once the local anesthetic is worn off, usually the aladinia comes back. But you've proven what it is, and then you can excise the posterior interossei nerve if the test has worked, and that solves out the problem. It doesn't work in every patient, and the reason is that that part of the forearm and the wrist is innervated by several nerves, including the palmar branch of the median nerve, the lateral cutaneous branch of the forearm, and the lateral cutaneous branch of the forearm and some branches of the radial nerve may merge on the radial side of the wrist. And also, if you look at this one, you can see branches from the ulnar nerve, dorsal sensory branch of the ulnar nerve coming all the way from the other side of the wrist. So these areas are very innervated. And what causes the problem is that sometimes it's not the nerve that we think that's causing the problem, it's another nerve. So understanding that can explain why, in spite of a nerve being completely divided, the area distal to that can have a hypersensitive allodynia. So the other thing that we see a lot is pain after distal radial fractures, and that you'll see this is a case, a 48-year-old woman who has had pain for 3 years after distal radial fracture. She was diagnosed as CRPS in the fracture clinic, and she is unable to use her left hand. She wears a black splint all the time and cannot rotate or extend or flex her wrist. And she's had several things done. She had a fracture radial, she had a lot of pain, so she had it fixed, and she had a lot of pain. Then she has had several operations, but the pain has not disappeared. Notice that there is a carpal tunnel incision there that's connected to the FCR incision. And if you think of that, that's a slightly dangerous approach because the palmar branch of the median nerve comes 5 centimeters proximal to the wrist and goes in that direction. So if you do that, you're likely to damage that. And that's what I thought. I mean, that there may be a nerve here that's causing a lot of pain and could be any one of those. And then she was diagnosed by CRPS. And what is CRPS? Now, CRPS is defined by certain criteria and is a continuous pain disproportionate to the inciting event. I found that slightly arrogant. It's like, I know how painful it should be, and this is more painful than it should be. Well, what do I know how painful it should be? They have allodynia, temperature asymmetry or skin color, swelling, and a decreased range of motion. That turns into stiffness. And then there are 2 types of CRPS, complex regional pain syndrome. Type 1 used to be called reflex sympathetic dystrophy, and type 2 used to be causalgia. But when you look at the abnormalities, they're pretty much the same. A lot of pain with swelling, vasomotor dysfunction and some changes. And the only difference is that in type 2, I know which nerve is injured, and in type 1, I don't know which nerve is injured. So it's a nice label, but it doesn't help me very much manage the situation. And just remember, CRPS is complex regional pain syndrome. It's not chronic regional pain syndrome, which is slightly different. And it's complex because people developed swelling and vasomotor changes and difference in appearance. And all those things are because of lack of use. So CRPS is a syndrome where people has got so much pain, they cannot use the hand. That's all it is. So what did we do with this lady? Well, try to find out where the pain is coming from. And after questioning her, it was very painful between my little 2 blue marks. And I asked her if I could mark the area of most tenderness. And she said, no, don't touch that. But she let me put an arrow near it. So that's the area. So what I did to test that this is a nerve pain that comes from there is put a bit of local anesthetic and again, send her for a coffee. She comes back 20 minutes later. And then suddenly she has the movement and she can rotate. And the reason she couldn't move the wrist is because it was too painful, because she has a neuroma, and every time she tries to move that, the skin pulls the neuroma and she's unable to move. So with all this, what I wanted to show you is that there are 2 different types of pain: nociceptive, when there is some tissue damage or some insult, and neurogenic or neuropathic, when the stimulus starts at the nerve, which could be a neuroma or a nerve compressed or a nerve damaged. And looking at the patient, it tells you the story. I mean, this is a game we play with the hand fellows. I just put a picture and they have to say what's the story. And for example, for this one, you could say, well, this is a hand of a male. That's a manual worker because it's very well used. It's got dirt ingrained, it's got callosities, except on the index finger. And that's because the index finger is not being used. He has had an injury at the tip of the index finger, and he has a little lump at the very end, suggestive of a neuroma. So just looking at that, you recognize the pattern, that there is somebody who has a lot of pain in the index finger, so he's excluding it all the time, not using it. And there are signs of disuse. So severe pain always comes with disuse. And if you don't use a part and you have it hanging down and you don't move it, it's going to get swollen. And you're going to have changes in color, you're going to have changes in temperature, shiny skin, and down the line, you're going to have stiffness. Yeah. And Tim Davis in Nottingham did a very interesting study. He just went to people in his department and asked them to keep the left hand by the body and not use it for half an hour. Just have it hanging down by the side of the body. Do the things you normally do, but do them just with one hand. And then he went to see them half an hour later, and he could demonstrate that the skin temperature was different, the color was different, and how the criteria, the Budapest criteria, were present. They didn't have any pain, But if you don't use it very quickly, the hand changes in color and changes in size. And you can measure that if you want. And then if you carry on not using it, what will happen is that you'll have decalcification of your bones. And that's what Sudek described many years ago and gives the typical radiographic appearance of somebody who has not used the hand for a long time. Let's move to another case. This is a lady who runs the care home and comes with bilateral wrist and hand pain that radiates into the arm, unable to work. And she's been diagnosed with several labels by several GPs, which eventually they agreed to refer her for assessment. Tell me about the pain you get in your hands.
The pain I'm getting, it's just affecting every aspect of my life. They're so weak, the pins and needles, shooting pains up my arms. I've got pain in my neck, and it's just making my life so miserable. I just can't cope with it any longer. I've got no strength. I can't make a fist until later on in the day, and I've just got no strength in them.
How are things at night?
Oh, it's keeping me awake through the night. I'm lucky if I can go for 1 full hour's sleep before I jump out of bed with pins and needles. My arms have gone dead. I've got shooting pains like red hot pokers. It's just terrible.
And how long have you had this?
About 2 years.
Okay. Thank you for that. So what do you do with a patient like this that comes with severe pain and has had several diagnoses? I mean, to me, this sounds a bit like carpal tunnel, although it's atypical and it's very, very painful. So I offered her a carpal tunnel release, and she wanted both sides done. And I advise her not to have both sides done because it's difficult to manage after. But I said, look, if you do one hand, I'm still not going to be able to sleep. I'm still not going to be able to live. I said, okay. So we did both sides done, and that's her after the carpal tunnel. So now it's 2 weeks since you had your carpal tunnel release done. How are things now?
Absolutely amazing. I can't believe the difference that this has had on my everyday life. I can sleep through the night. I've got no pain at all. I've got a little bit of discomfort from where I've had the surgery, which is to be expected. That will soon go, and my life will be back to 100% normal. My neck's been released. I've got no shooting pains, no pins and needles, nothing. I can do everything. Or when I get this discomfort gone, which is probably another week, I'll be able to do everything that I could do 2 years ago.
And just make a fist for me.
Yeah.
And straighten them out.
Yeah.
Is that better than it was?
Absolutely brilliant.
Brilliant. Thank you very much. So it is well known that nerve compression can cause a lot of pain. Let me see if I can move this on. And this recent paper by Paco del Piñal about that, the outcomes of releasing carpal tunnel in people diagnosed with complex regional pain syndrome. And there is a talk by him in this series of webinars regarding this. And I think that's the type of patient that I do see reasonably often, and they come with a label of CRPS, and then they end up being my best friends. And just make a fist for me. Excellent, and straighten your fingers. So that movement is all right now, isn't it?
Yes, yeah.
Just tell me, how was the pain beforehand?
Atrocious. I couldn't. Well, it was. I never slept properly for.
How long did you have that?
Oh, a month, 6 weeks. 6 weeks.
Okay. And what tablets were you on?
Naproxen, pregabalin, amitriptyline, and codeine phos.
Okay. And then we said on the day of the operation that we'd slowly stop that.
Yeah.
Is that right?
Yes.
How did that go?
It went fine. The day after the operation, the pain had gone.
And you could move your fingers all right?
Yes, yeah. I could clench my fists. Over night time, when I got the pain, I couldn't clench my fists any more than that.
Yeah.
Because it was just horrendous, and it went right down to my elbow.
Okay, brilliant. So you're happy you had it done?
Oh yes, yeah.
Brilliant. Thank you very much for that. So I just wanted to illustrate the point that these patients treated, they seem to do very well. But of course, there is this thing that every book says, that somebody with CRPS, you should not operate on them. You should not really touch them because you could make them worse or it could be a disaster. But if you don't treat them, what happens? This is an example, 65-year-old lady, 1 year after distal radial fracture, a lot of pain, GP diagnosed with fibromyalgia, and the surgeon who treated her diagnosed her with complex regional pain syndrome. And that's telling her a story. Oh, sorry. So tell us what happened to your wrist.
Well, I broke my wrist a year ago, and then they put a pot on for 4 weeks, and they put it on tight. And then they did an operation, and
to fix the fracture.
the fracture.
And how was the hand after that?
I've had lots of pins and needles and pains.
Okay. And you've been having pain for a year now.
Yes.
And it has got very stiff, hasn't it?
Yes, it's stiff. I can't straighten my fingers or...
Okay, if you try to bend the wrist, how much movement have you got?
Can't go that way.
Yeah.
I've got that much.
Okay, yeah.
And...
If you try to turn your palm upwards...
I can do that.
Yeah.
But I can't do that.
Okay, right. And if you try to make a fist with your fingers...
That's it.
Yeah, and if you try to straighten them...
That's all I can do.
Try to make a fist again.
I can't bend my thumb.
No. Okay. And you are on several painkillers. You are on paracetamol, anti-inflammatories, amitriptyline. Does that help?
Well, amitriptyline's for my fibromyalgia, and so is Celebrex. So all I'm allowed to take is paracetamol.
Okay.
But
okay.
It's not helping a lot.
Okay. Thank you very much for that. So that's a little bit what happens when people with neurogenic pain, she's telling you the description of neurogenic pain, don't get treated. And what happens is that they cannot move and they get very, very stiff. Not just the wrist, but also distal to the wrist, the proximal interphalangeal joints in particular. Now, let's go to another case with a different problem, actually. This is a 55-year-old hairdresser that is referred with pain in both wrists. And she wanted a diagnosis, and that's her talking. Let's see if I can get this to work. Now tell me, what about do you get the pain?
I'm getting nerve pain in my right arm from the elbow shooting up to the shoulder.
Yeah. What else?
In relation to fibromyalgia, I have all over body pain.
Which bits are most painful?
My wrists.
Yeah.
My fingers.
Yeah.
Backs of my knees.
Yeah.
Both hip pain on both sides, which is getting worse now.
Yeah.
Ankles. It is all over my body, but mostly where my joints are.
Okay.
Sometimes I can't.
And how do you feel in general?
Now very, very unwell.
In what way?
Tired and in pain. My skin is sensitive.
Okay. And what do you take for it?
I am on a 20 milligram morphine patch. I've been on it for many years. They can't give me any stronger.
Does that sort out the pain?
I've been on it for that many years. I don't know. I don't know if the pain's getting worse, and it's just keeping it from getting worse than what it is now. But I use Oromorph as well to top up paracetamol.
Okay, thank you for that. So this is somebody who has widespread musculoskeletal pain in the 4 quadrants of the body. So both arms, both legs, the hips, the back, with associated problems like disturbed sleep or what's called unrefreshing sleep. So they wake up tired with associated symptoms. They often been diagnosed having irritable bowel syndrome or something like that. And they get the label of fibromyalgia. And that affects 2 to 4% of the population. So I'm sure you'll see them in your clinic, like I see them in mine. And the American College of Rheumatology in 1990 created some diagnostic criteria And one of them was 11 out of 18 tender points. And the tenderness is mostly over muscle or fascias rather than the joint. So it's not joint pain, it's muscle pain. And this was revised in 210. And this thing about the 11 out of 18 tender points was abolished then. They got rid of that, perhaps to make it easier to diagnose. And then the diagnosis formally is made using two scales of pain. One is the widespread pain index, and one is the symptom severity scale. So this is a controversial condition. Fibromyalgia is not new. Things like that were described in the 16th century. And before the 1980s, this was called fibromyositis and things like that, which was not good because it's not an inflammatory condition. It's not an autoimmune condition. We know that, but it is a painful condition. And one thing I do with these patients is just check their blood pressure. And the reason I do it is that I just put the sphygmomanometer up to 200 millimeters of mercury, and they'll find that very painful, and they'll tell you. So I don't ask them. I just say, I'm just going to measure your blood pressure. And as you put it up, they'll complain that that's very painful. And that's because they perceive that pressure as pain all over. So the issue is one of the thresholds of what is painful. And things that we consider normal stimulus is perceived as pain. And some people say, well, it's all in the head. They're imagining that pain. And the answer is no, they're not imagining that pain. They are feeling that pain. And that pain is real. Further to that, substance P concentration, which is related to pain, is about 3 times the normal level in fibromyalgia. If you take that substance P or serum from people with fibromyalgia and you inject it in rats, that produces a pain sensitization and disturbed sleep. So there's something biochemical here. Skin biopsies show atrophy of the C fibers that conduct the pain. There is a change in hormones, and brain imaging shows changes in gray matter. We don't understand very well why this happens, or if all these changes are a cause or a consequence of the fibromyalgia. But the fact that we don't understand fibromyalgia should not be a reason to dismiss these patients. These patients have a problem and they need help. So apart from the nociceptive and the neurogenic pain, there is centrally mediated pain or sensitization. And we need to listen to the patients and try to help them. And the fourth group of patients with serious pain is this kind of thing. This is a 45-year-old man. He used to work in construction, had an accident that worked 9 months ago. He was cleaning a cement mixer while a colleague turned it on, and that caused a twisting injury to his wrist. Since then, he has had pain in the wrist and the hand. He has had several investigations, including radiograph and MRI, that have been always normal, but he has been unable to return to work, and he is suing the company for compensation because of having had that injury and not being able to work. And that is his hand. So if you look at the hand talks to you. He's got ingrained dirt, he's got calluses, and he's got a very well used hand. If you had not used your hand for 9 months, it would not look like that. Calluses disappear in a few weeks. So just having a friendly chat with him, I said, well, what do you do with your time now that you're not working? He said, well, no, my brother is a constructor, he's a builder, and I go and help him most days, and so what he was doing is not turning up to his job, but go and work for his brother. But if you look at the hand, this is a well-used hand. This is not a painful hand. A painful hand cannot do this. And there is good evidence that people can tell you that they have pain that is made up, basically. And that can be conscious or unconscious, and it's because they get a certain gain. It can be a financial gain, and most of them are conscious. These are people who come and tell you because they know they're going to get a compensation. They're not complete liars in some way, okay? Don't accuse them of lying, because sometimes there is certain suggestion. It's like, if you come to me and you say, Carlos, do you have back pain? Because if you had back pain, you had to fall out work, it will give you £5,000. Well, I'll say, no, I don't have back pain, but by tomorrow I'll start concentrated on my back, you know. I said, well, maybe I have a little bit, you know. In a few days, well, I do get back pain sometimes. Yeah, I remember when I'm walking uphill, well, definitely have back pain. And after a few days, I'll convince myself that I have back pain. And I'm not lying. I'm sure I've got back pain. And until you give me the £5,000, I'm going to get more and more convinced about it. Some other people get an emotional gain or get an advantage at home. I don't know, maybe their wife would be nicer to them if they have pain of some kind, or they get a certain advantage, emotional or familiar. So what I wanted to say is that types of pain in my practice fall in one of those categories: nociceptive, neurogenic, centrally mediated, or malingering, and that you can tell which type it is. The other thing is that chronic pain is often treated with all these painkillers that we've seen. And when you ask the patients are not sure that that helps, but they are sure that that's causing significant side effects, and they seem to get an addiction, or at least be worried about an addiction. And the newer guidelines in the UK, published last year, are to avoid all these type of painkillers in the longer term. They do not sort out the problem. So if you want to classify these pains, it's about pattern recognition. If you listen to the patient, they tell you that they got pain that's reasonably well localized, is related temporally to an injury, sometimes with sign of inflammation, worse with activity or movement or loading. But if you rest it, it gets better. And if you give them anti-inflammatories, it gets better. And you have corresponding clinical signs to the clinical symptoms, that is nociceptive pain. This is the one we are good at treating. We are reasonably good at diagnosing. We are reasonably good at treating. Then you have people who come with very severe pain, often in a nerve distribution, an anatomical nerve distribution that makes sense to us. And as a clinicians, we like that, if it's in a dermatome or in the region of a nerve. And the pain characteristic is important. It can be burning, shooting, or pricking. Now, this pain doesn't respond well to simple analgesia. Simple analgesia that work in the periphery are not going to affect pain that starts in the nerve higher up. Even if they rest it, they have pain. Even at night, they have pain. And that makes life very miserable. Life is exhausting. And sometimes they have altered sensation or numbness, as well as the pain, which just puzzle the patient. They say, oh, this bit of the hand is numb but painful. And because of all that, it has a huge functional impact. Then you have pain that is widespread. And if people come to you with hand pain, but also they have pain above the elbow and below the waist, now you need to hear alarm bells. They'll be fatigued. They don't sleep well. They feel unwell as well. This is general feeling and cognitive problems. They'll tell you that they've got brain fog, that they cannot concentrate. And they have tender points on the muscles. And sometimes they even have sensitivity in other senses, like they're quite bothered by noises or lights and smells. I remember when I was training, my professor telling me, don't operate on patients that come into the clinic with sunglasses or tinted glasses. The reason they have sunglasses is because they got photophobia, because they're sensitive to the light. So that's something you need to take into account. And distinguishing those two is not that difficult. If you look at the characteristics of neuropathic pain versus non-neuropathic sensitization pain, you can tell from the history pretty well and know which type of pain it is. And then the last bunch is malingering, where the patient is making it up. And there are inconsistencies in that they have lots of symptoms, but they have no signs. So they complain a lot, but the hand looks all right. And they've had lots of investigations that are normal. And they may have a secondary gain. And I usually ask the patient if they had an accident at work or a road traffic accident, do you have a claim? Have you got your compensation? What the stage is that at? The other thing that's interesting is that they often come to see me and they're not really interested in the treatment. What they're interested is me producing a letter saying that they're suffering a lot and they have a big problem. So they can go to their solicitor, their lawyer, to strengthen their case. And there is a focus on blame. I often ask them whose fault it was. And they find somebody else whose fault it was a colleague, or was the company, or it was somebody who was cleaning the floors, or whatever. So just be careful with those. Now, in my experience, if you do a clinical practice, they are very rare. So it's better not to assume that they are malingering, and they'll fool you sometimes, rather than just suspecting genuine patients and not treating them because they could be malingering. That's not fair to the patient. So don't overdo it on the malingering thing. If you have a medical legal practice where you're doing reports on patients, then you will see many more of those. So patients with pain fall in one of these groups. The problem is that the groups overlap to a certain extent, and that is an issue, and you need to recognize the pattern. And the only way to get to diagnosis is really listen to the patient. So in summary, I wanted to say that pain is a complex sense, that most patients with chronic pain fit nicely in one of those 4 patterns. Sometimes they overlap, and that the pattern can be deduced or decided based on the clinical history. Clinical history is 90% of the decisions, and then knowing the pattern help you decide how to manage these patients. This is a pub for hand and upper limb surgeons in Derbyshire, in Belper, near where I live. Thank you very much for your attention.